Mobiles phone, please. Thank you. All of you. Don't keep it on your desk, please. Keep it inside the pockets. Thank you again. I don't want anyone to leave the class during the middle of the lecture, please. So kindly follow the instruction and keep your mobiles inside the pockets. Thanks a lot. Thank you very much. All right, Shabab. In the morning you have a lecture, and that lecture was about the placental hormones. Did you finish the lecture? Yes. Was there any difficulty in the lecture? That was a pretty easy piece of lecture because that's only about the characteristics of some hormones which are coming out of the placenta. And if you see, many of the hormones are already known to you. Estrogen, progesterone, the main hormones, they were already known to you. Nothing new in those hormones. The only hormone of importance or hormones of importance are HPL and HCG. These are the two most important hormones that you need to know. I think Dr. Mushtaba has told you about the hormones. The most important area in that lecture was interpretation of the graphs. How do you see the run of the graphs? How the hormones are increasing, and what time of pregnancy is showing the maximum of the hormones or the minimum of the hormones, and is the graph changing, coming down or not coming down? That you need to know, especially for the hormones like HCG, HCS, which is HPL, estrogen and progesterone. Please keep these four hormones. Four hormones are very important. You have to see them graphically, and this kind of interpretation will be asked from you in the examination also. Okay, so you need to compare, and that is very, very easy really. Okay, that is not at all difficult. So we need to know about the clinical situations in which hormones are affected or they are changing. Having done the placental hormones, the issue is that we are done with the pregnancy and we are done with the placenta. Everything is ready. Now we are preparing for a journey, a new journey, and that is about how the baby is delivered. We need to know about the physiology of the delivery of the baby. How the baby, after such an excellent adjustments in the body of the mother, a perfect adjustment for 9 months, baby has grown, baby is ready, mother is anticipating, it's time for the baby to be born now. Okay? Now we'll have to see all the preparations which are dealing with the birth of the baby, Vilada. So the whole issue is now surrounding the process of Vilada. Let us see what happens. How does it do? We are looking from the physiological point of view. We are not looking at it from the gynecological and obstetrical point of view. Okay, that will come again inshallah in the 5th and 6th year, that how the child is present inside mother, what are the anatomical changes which are coming in different parts of the uterus and in the vagina, how the birth canal responds, how the fetus changes its position, what are the different positions of the fetus. That is all about obstetrics and gynecology. At this stage of yours, we are dealing with physiology maximally. It means we'll be talking about the uterus, the functions of the uterus, the responses of the uterus, the responses of the birth canal, hormonal changes, mechanical changes, how are they happening in the body? This is our area of discussion. Okay? It's a very complicated topic, the labor physiology, but still we are taking it towards the physiological side, not the obstetrical side. Okay? So with this perspective in mind, that physiological perspective is there, we are beginning our discussion. Okay? Well, Shabab, first of all, let us see the lecture, and the title of the lecture is Physiology of Parturition or Physiology of the Labor. Okay? Now, we are introducing a new word, that is parturition. There is another word which we call it labor. Okay? I hope many of you know about the meaning of the word labor, which pertains to the delivery of the baby or the process of vilada, the childbirth. Okay, the whole process by which the child is born together, okay, that process constitutes labor. And another name for labor, the process of labor, is parturition. These words are used interchangeably. There might be slight difference in the meaning. Parturition is a little more than labor because it starts a little earlier than labor. But overall, parturition means labor or the process of the childbirth. Okay? Are we following the instructions of the class? I don't think so. Where is your mobile? Is it inside? Inside, please. Okay? Everyone. I don't want any mobile. I don't want any. Let us see the definition, please. Okay? Technically speaking, the process of bringing the child into the external environment or the extrauterine environment outside in our world from a very safe area of the mother's womb, the cavity of the uterus, the process by which the child is brought forwards, or the process of bringing forth or delivering the baby, this process is called parturition. Okay? Well, this is a very complicated process. It involves many interactive sequelae, and finally the child is delivered as a result of many adjustments in the form of hormones and the local environment of the uterus. Okay? How the myometrium or the uterus is responding to the hormones and to the local factors and to some other neural factors. Finally, the process ends up in the delivery of the baby. Okay. Uterus, first of all, do you agree with me that uterus is the excitable tissue? Yes or no? Yes. Uterus is an excitable tissue. And why do you call it excitable tissue? What is the reason? Why? Okay. Abdul Aziz, yeah? Controlled by hormones. But Shabab, if anything is controlled by hormone or sensitive to hormones or some chemicals, will you call it excitable? Muscle. Okay. Now the concept is changing. Uterus has muscles. That's why you call it excitable. Okay? If it has muscles, why are you calling it excitable? Because the muscles contract. And why do the muscles contract? Stimulus. So it means in response to the stimulus, if there is a process of contraction, that tissue is excitable, isn't it? Okay, I'll keep your words. Are neurons excitable? Yes. Neurons excitable or no? Yes. They are. Do neurons contract? No. But they are excitable. You are calling them excitable. They respond and they produce also something. Okay? And they are excitable, as you are saying. So muscles are excitable and the neurons are excitable. What is the common thing between muscles and neurons which make them excitable? Oh yeah, thank you dear, thank you very much. The word is action potential. Okay? After action potential, you have impulse running in the neurons or in the nerve fibers, and you have the process of contraction happening in the muscles. But the commonality is both are excitable because they show action potentials. Muscle tissue, any type of muscle, excitable, yes or no? Skeletal muscle, cardiac muscle, smooth muscle, all are excitable. Do we agree? And the neurons are also excitable. So the common point is action potential. Okay? All right. Uterus is made up of the smooth muscles or skeletal muscles? Smooth. All together, all muscles. And where are these muscles present? In which area? Yeah. What do you call that collection? You call it in the uterus, in like which area, which part or which layer? What do you call it? You call it myometrium, endometrium, myometrium and perimetrium, like this, isn't it? Okay. So myometrium, smooth muscles, and they are joined together. They are not separate. They are not multi-unit type of muscles, mean every smooth muscle is separate from other and they are just put. I have a bag like this, and in that bag I put one smooth muscle too, and I put millions and millions, and I close this bag. This will not make myometrium. I have to join one smooth muscle with the other one, the third one, fourth one, like this, connections, okay? They are connected. If they are connected, they are making a single mass. If they are single mass, then this is known as the single unit type of smooth muscle. So please remember, in uterus, it's a single unit. In all the viscera, generally speaking, whether it's GIT, whether it's respiratory system, whether any other area where you have the smooth muscles, generally speaking, okay, where organs are there, in all those organs, the collection is in the form of single unit, not the multi-unit. Multi-units means separate. Multi-unit are present in some of the areas, and multi-unit are present in the skin, like this, separately, or in the eye. You may have the multi-unit smooth muscles, but in the other organs, single unit. Uterus is one unit complete. The wall of the uterus is one in continuity. So all the smooth muscles are joined together. Okay, and that is making a very unique property. So if they contract, one area will not contract. What will happen? Yeah, the whole thing will contract within a short period of time. Maybe starting from one area, but then the contraction will spread to all over the uterus. Starting from one part, okay, but quickly it will expand and it will continue down in the uterus, and the whole thing will have a contraction or a wave of contraction going on. So this is the property, all right? Don't forget that. Uterus is spontaneously active, means uterus has the capability to show action potentials, the muscles, and to contract. Remember one point. Smooth muscles, they have spontaneous depolarizations or action potentials, but the question is, one part of the uterus or one area of the smooth muscles should be the pacemaker. Pacemaker means just like heart, qalb. You have SA node majood, and that is the starting point. And then from that it spreads down into the ventricles and all the areas, as you know. Just like that, smooth muscles also need a pacemaker, yani one area to start the activity, and then quickly the whole thing will spread in the surroundings or in the area. Okay. Now, where is the pacemaker of the uterus present? This is a question. Okay. Well, the pacemaker is present not in the body or in the fundus. We believe that it starts in the lower part of, no, not in the lower part, okay, you have to go up and you have to go into the fallopian tubes, where you have the opening of the fallopian tubes into the uterus, okay, somewhere close, very qareeb to that area, in the last part of the fallopian tube where it is entering into the uterus. That probably is the area where the pacemaker is present, okay, and that initiates the activity, and then the activity quickly spreads into the fundus muscles and the body of the uterus, and then it can go down into the cervix of the uterus also. Okay, so that is the starting point that you have to keep in mind. Is that okay? All right. Now, who stimulates that? What are the factors which are controlling that pacemaker activity? Yeah, could be hormones, could be some local factors which are controlled by the hormones, or could be some other factors like mechanical changes, or like some effect of stretching or some change in the wall. So could be some mechanical factors, hormonal factors, or a combination of these factors which is causing the activity. Okay, so actually we are dealing here mainly with the hormones and with the mechanical factors. We'll see that inshallah. That was an introduction to know about the characteristics of the uterus. Okay, so uterine muscles are not separate muscles. It's a complete package. If activity is starting in the upper part, it will quickly come down and it will show the contraction in the body and in the cervix region also. Okay. Now, getting to the hormones, and we know about some of the hormones. If you remember, well, the hormones which are important in the pregnancy, these hormones are definitely in large amounts. We have estrogen and progesterone, which are very, very important, which are important for the uterine muscles. Now, I'm not talking about those hormones which are required for other functions of the body, like human placental lactogen and HCG. They have got other functions, mainly metabolic functions and some other functions. But I'm talking about those hormones which are focusing the smooth muscles. If you need to have hormones which are acting on the smooth muscles, then you have got to see estrogen and progesterone. Okay, these are the most important hormones, and they are kathir in the pregnancy. You know that. Okay, as the pregnancy is advancing, you saw in the morning that the graph is going up really for the estrogen and progesterone, isn't it? Okay. So keep in mind, we have progesterone, we have estrogen. Well, there should be a balance between progesterone and estrogen because they are opposite to each other. Estrogen and progesterone, they are helping overall to the mother and to the fetus, but in some of the areas they have a difference of opinion. They say, la, okay, I want to contract this. Other is saying, no, I want to relax this. Okay, so for one area like smooth muscles, they have got opposite actions. Now you are considering the uterine muscles. It is an issue of pregnancy. The baby is موجود inside the mother's womb, and there is a fight going on between progesterone and estrogen. Okay, progesterone is basically the inhibitor or the relaxant. Estrogen has the capability to increase the sensitivity of the smooth muscle and to make them more excitable, yani more contraction. Now this is an issue of pregnancy. It's the period of 9 months that you have. Now progesterone, estrogen, both are موجود in very good quantities. In the pregnancy, logically, till the end of the pregnancy, who must win the war? Progesterone or estrogen? Progesterone. So all the time, right from the beginning of the pregnancy to takriban end of the pregnancy, what will happen? Progesterone is having an edge, and progesterone is controlling the situation. There is a ratio, estrogen and progesterone ratio موجود, but in that ratio, what happens? Progesterone has an overwhelming effect and it tries to inhibit the muscles more. Estrogen is موجود, but estrogen cannot do anything because there is a guard موجود, and that guard is progesterone. Okay, now two things should happen. Either that guard should go away, or the estrogen should increase to a very high level so that it becomes more powerful than the progesterone. Even if progesterone is موجود, if the quantity of estrogen is increasing, then maybe it will overcome the effect of progesterone. Okay, or if the progesterone goes down and it disappears, then estrogen is left alone, and then there is no problem. Let us see what happens at the end of the pregnancy. Okay, look at the slide. In the third trimester, when we are in the 7th month of the pregnancy, the relationships are now changing. Okay, progesterone was going up slowly, but now the graph will remain stable takriban after that time. Okay, in the last trimester there is a slight change in the progesterone, and there is a greater change going up for the estrogen. Okay, yani estrogen levels are increasing. If estrogen levels are increasing, then the power of estrogen is increasing, and the sensitivity of the muscles is now shifting towards estrogen side or the progesterone side. All right, okay, so you are making things possible for estrogen to work. The ratio of the estrogen to progesterone changes, and since estrogen is now increasing, what will happen to the ratio? ratio will also increase because estrogen is increasing, isn't it? And that is making estrogen more workable in that condition. Are you following me so far? Okay. This is one issue. In their working perspective, what are estrogen and progesterone doing for the uterus? Because now their focus, their hadaf is uterus, and their hadaf inside uterus is the smooth muscles. They are working on the smooth muscles. If estrogen is working more, well, the situation will change. You will have excitability and contraction. If the progesterone is there, progesterone will try to cool it down. Don't move, relax, just relax, okay? It's not the time. Now see, what is progesterone doing? When progesterone is موجود in abundant amounts in the pregnancy time, what is it actually doing? How is it working? Chemically, mechanically, or what is it doing? Look, one by one. It is decreasing the gap junctions of the uterine smooth muscles. Remember, I told you that the muscles are connected by numerous gap junctions, connections, okay? If you have more connections, these connections are the electrical, like kaharba. Okay, from one muscle to other muscle, the message can go easily. If you have more connections, more easy spread of the message, more excitability, very good chance of action potential, spreading and contraction. Less number of gap junctions, then one muscle cannot transmit the information to the other muscle, or a very little transmission, so sensitivity will be low. Now, you know the progesterone. Progesterone does not want the muscles to contract, isn't it? It wants the muscles to relax. Will it increase the gap junctions or decrease the gap junctions? Oh, it will control the number of the gap junctions, and it will not let number increase. This is one thing, okay? So it means one mechanical effect which is produced by, this is the mechanical effect, isn't it? Gap junctions are the proteins, connecting proteins actually, okay, called connexins. These are connexins. One from one smooth muscle, other from other smooth muscle, and they form like this, they attach, and they form a tunnel or a connection, okay? So anyway, more gap junction means more chances of sensitivity and excitability, okay? More communication. Progesterone will inhibit it, number one. What else is progesterone doing? Can you see from the slide? It is decreased receptors of oxytocin. All right. Now, do we know anything about oxytocin?
Yes.
Great. Okay. Oxytocin. What will it do to the smooth muscles? Contraction. Progesterone does not want it. Progesterone tries to inhibit. Progesterone cannot affect the release of the oxytocin. It cannot go to the pituitary. It cannot do anything. But one thing it can do, it can go to the uterus and say, I will not allow you, okay? I will not allow you to work. How? It will control the number of receptors of the oxytocin which are موجود there, okay? So, progesterone is causing the down regulation or decreasing the number of the receptors of the oxytocin. Shabab, any hormone is helpless, is useless if the receptors are not موجود. If you increase the hormone in the blood, keep on increasing in the blood, no use. There is no faida at all. If the receptors are موجود, hormone is good. If the receptors are not do, you are filling the blood with the hormone and it is useless really, okay? So, the idea is that progesterone decreases the sensitivity of the uterus towards oxytocin by decreasing the number of the receptors of the oxytocin. All right? Agree? This is a hormonal effect. Progesterone is a hormone, and acting as a hormone, it is producing an effect. It will block the hormonal effect. Okay? What is the next thing which is maktub there? Prostaglandins are the local workers. They are the local workers موجود. Okay? These workers, there are different types of prostaglandins. Some are relaxing the smooth muscles and some are contracting. For example, prostacyclin PGI2, that is a relaxant. PGF2 alpha or PGE2, they are the contractile prostaglandins, okay? And there is a tawazun actually. Now, progesterone wants relaxation or stimulation. Which prostaglandin will it favor and which prostaglandin will it inhibit? I2 it will try to favor, okay, and PGF2 alpha, all right, okay. So it will try to inhibit the formation of PGF2 alpha and other prostaglandins which can cause contraction of the uterus, isn't it? Prostaglandins are very effective locally for causing, I'm sure you have done the pharmacology of the uterine stimulation also, and prostaglandin analogs are so important. Dr. Ahmad must have told you about that, all right? Have you? Not yet? Why? In the previous lecture, what was the lecture?
About contraindicated drugs.
The drugs for the pregnancy. Oh, okay. I'm sorry for that. I thought you have done it. I thought by changing the tartib of the lecture, you did this before. That's good. That's great that you are doing it first and then you will do it. I'm relieved actually. Thank you. So, anyway, prostaglandins are very powerful, and you will see the clinical use of the prostaglandins in the delivery of the baby, okay? Prostaglandin F2 alpha and some others are very, very effective, all right? Okay. Now let us see. Progesterone is affecting two types of hormones and trying to inhibit those hormones. One hormone is a systemic hormone. Which one is the systemic hormone? Oxytocin. And one is the local hormones or the autocoids. What are these hormones? Prostaglandins. It is decreasing their production, it is decreasing their receptors, okay, also. So, khalas, both. Now, there is one more effect. Progesterone is also working on the membrane, the channels and the membrane of the smooth muscle, and it is trying to change the membrane potential also. Okay, this effect is the mechanical effect or the electrical effect? What do you think? Oh yeah. So see, out of these four, if you want to classify this, number one is kind of a mechanical thing, and that could lead to the electrical communication also between, because ions will flow from one smooth muscle to the other by the gap junction. So in case of excitability, so number 1 and number 4, they belong to mechanical and electrical actually, basically more electrical. Number 2 and number 3, these are the hormonal effects or the endocrine effects that are being checked by the progesterone, isn't it? So in this way, this is the package of the progesterone, how it is working. Now let us have a look at the other side. What is estrogen doing, please? The effect of estrogen. What is it doing? Yeah. Just the opposite. Now it's easy, okay? You can classify the effects and you will see it's kind of opposite, takriban opposite, if not exactly opposite. Almost all the effects are being opposed by the estrogen. This is the way how these hormones work, electrically or electromechanically and hormonally also, okay? Yeah.
These changes are happening at the third trimester.
Well, these changes in the first two trimesters and in the beginning of the third trimester also, the main effect is controlled by this hormone, this one, okay? And estrogen is maujood, but progesterone is more effective quantitatively and functionally. So both are maujood all the time, okay? But it is under control of progesterone mainly, so estrogen cannot do. The main job is done by the progesterone, okay? As you are approaching towards the last part of in the trimester, third trimester, but in the last month of the third trimester when you are going, then things are changing. Now estrogen is increasing and the control is going in hands of estrogen more, and it is making the sensitivity. I'm not saying that contractions will start at that time, but the sensitivity of the uterus is changing now. It is becoming more excitable, more gap junctions will appear, and I'll show you, okay? Let us see. Okay, so as you are approaching towards the end of the pregnancy, in the last month of the pregnancy, then it is time that estrogen is now developing its power, more quantity, ratio is changing. It will increase upregulation of the receptors of the oxytocin. Progesterone is maujood, but now the progesterone is becoming weaker. Progesterone is maujood so that estrogen is not alone. If only estrogen is موجود at that time, contractions will start really, okay? But since progesterone is also موجود, it will still fight. It will still fight. But now estrogen is winning. It is now putting more receptors over the cells, and progesterone cannot do anything. The only thing is that estrogen cannot cause contraction right now because progesterone is opposing the contraction, but the sensitivity of the muscle is now changing. Sensitivity means the response, and the response in the form of excitability is depending upon the number of receptors actually.